Med history.
Tularemia is a naturally focal acute infection affecting the lymph nodes, skin, and sometimes the mucous membranes of the eyes, pharynx, and lungs. Tularemia occurs with pronounced symptoms of general intoxication, prolonged fever, generalized lymphadenitis, hepatosplenomegaly, polymorphic rash, and other symptoms. Specific diagnosis of tularemia is carried out using serological reactions, ELISA, RA, RNGA, PCR, and a skin allergy test. In the treatment of tularemia, antibacterial, detoxification therapy, surgical autopsy, and drainage of suppurated bubons are used. Tularemia was first mentioned in 1818 in Japan under the name Yado bio disease. The pathogen was discovered later, in 1896 in Norway. In 1910 to 1912, American researchers managed to isolate and artificially infect rodents with the bacterium. The disease got its name from the Tulare area in California, where the expedition took place, where a variety of rodents live. The causative agent of tularemia is the aerobic gram-negative rod bacterium Francisella tularensis. Tularemia bacillus is a fairly tenacious microorganism. It remains viable in water at a temperature of 4 degrees C for up to a month, on straw or in grain at 0 temperature for up to 6 months. A temperature of 20 to 30 degrees C allows bacteria to survive for 20 days, and in the skins of animals that died of tularemia, the microorganism persists for about a month at 8-12 degrees. Bacteria die when exposed to high temperatures and disinfectants. The reservoir of infection and its source are wild rodents, birds, and some mammals, hares, dogs, sheep, etc. Rodents, vole, muskrat, etc., make the greatest contribution to the spread of infection. A sick person is not contagious. The transmission mechanism is the most common. The microbe enters the body of animals when bitten by a tick or blood-sucking insects. Tularemia is characterized by infection of animals when bitten by an exotic tick. A person becomes infected by contact with sick animals, skinning collecting rodents, or by eating food and water infected with animals. The respiratory route of infection is realized by inhaling dust from bacteria-infected grain or straw in agricultural industries, processing of vegetable raw materials, meat processing plants, slaughter of cattle, etc. Despite the low probability of infection with tularemia outside the natural source of the pathogen, it is possible to get sick in contact with products and raw materials imported from epidemiologically disadvantaged areas. Human susceptibility to tularemia is extremely high. The disease develops in almost 100% of infected people. There are 3 geographical races, subspecies, of F. tularensis with different properties. Nearctic race, Francisella tularensis nearctica ols. Widespread in the USA, highly pathogenic, that is, it easily causes disease. The Holarctic race, Francisella tularensis, Holarctica ols. And the Japanese version of Francisella tularensis, Holarctica var. Japonica rod. Found in Europe and Russia, moderately pathogenic. The Central Asian race, Francisella tularensis, Media asiatica Ikem. Moderately pathogenic, common in Asian countries. Symptoms of tularemia incubation period, from 1 day to a month, more often 3-7 days. Common symptoms, an increase in body temperature to 38-40 degrees. Intoxication, weakness, muscle aches, headache, remitting fever, hyperemia of the face, conjunctiva, mucous membranes. Fever can last from a week to several months. Local manifestations, bubonic form, enlarged lymph nodes, possibly with the formation of abscesses. Ulcerative bubonic form, skin ulcer with regional lymphadenitis. Ocular bubonic form, conjunctivitis with lymphadenitis. Anginous bubonic form, sore throat, tonsils with ulcers. Abdominal form, abdominal pain, vomiting, diarrhea. Pulmonary form, bronchitic and pneumonic variants. Generalized form, fever, intoxication, muscle aches, headache, delirium, hallucinations. Pathogenesis of tularemia. The entrance gates for infection are the skin, mucous membranes, even intact ones, and lung tissue. In the place where the bacterium has invaded, primary damage develops. Then the microbes penetrate into the nearest regional lymph nodes. In them, they multiply and partially die, while the lymph nodes increase. An enlarged and inflamed lymph node is called a bubo. It is soft to the touch, can be suppressed. At the same time, endotoxin is released, which causes local inflammation of tissues and symptoms of initial intoxication. Bubon is an inflamed lymph node. Over time, the lymph nodes lose the battle, and the pathogen penetrates further into the blood. It circulates in it and infects other parts of the body. Secondary bubones are formed, which are usually smaller and do not build up. When the infection is generalized, Tularemia granulomas appear, nodules in organs up to 4 mm in size with necrosis in the center, resembling cottage cheese in consistency. Thrombosis of nearby blood vessels may occur. Lymph nodes, especially in the area of penetration of the pathogen, are often suppressed and opened, which causes long-term non-healing ulcers to form on the skin. In the future, an allergic inflammatory condition occurs, which slowly subsides upon recovery. In the pulmonary form, the pathogen enters the alveolar macrophages in a few minutes, where it multiplies very quickly. A lot of neutrophils, white blood cells, rush to the site of inflammation, which help repair damaged tissues and eliminate infection. But due to massive bacterial contamination, there are too many of them, and they begin to play not a protective, but a disastrous role. Excessive inflammation occurs, and cells and tissues are destroyed. There is pronounced inflammation with hemorrhagic edema, purulent nodular necrosis of lung tissue, and alveolar exudation, exit into the cavity of the alveoli of blood plasma. At the same time, the intrathoracic lymph nodes increase. Further, with the development of the disease, granulomas are formed, and lung tissues are destroyed. By the end of the second week of the disease, a humoral immune response develops. Antibodies of class M and A are synthesized. A little later, antibodies of class G. Antibodies together with plasma proteins involved in the immune response complement. Interferon gamma and tumor necrosis factor slowly cleanse the body of the pathogen. Nonspecific laboratory techniques, general analysis of blood, urine, show signs of inflammation and intoxication. In the first days of the disease, neutrophilic leukocytosis occurs in the blood. Subsequently, the total number of leukocytes decreases. The concentration of fractions of lymphocytes and monocytes increases. Specific serological diagnosis is performed using RA and RNG, reactions of direct agglutination and indirect hemagglutination. With the progression of the disease, the titer of specific antibodies increases. From 6–10 days after the onset of the disease, it is possible to determine tularemia using immunofluorescence analysis, ELISA, the most sensitive serological test for tularemia. PCR can be used for early diagnosis in the first days of fever. A quick and rather specific diagnosis can be carried out with the help of a skin allergy test with tularemic toxin. It gives a result already on the 3–5 day of the disease. Since the isolation of bacteria from blood and other biological materials is a certain difficulty, bacteriological sowing is rarely carried out. On the 7th to 10th day of the disease, it is possible to isolate the pathogen by back-seeding of excretory ulcers, punctate of bubones, but the laboratory tools necessary for sowing this culture are few. In the pulmonary form of tularemia, radiography or CT of the lungs is performed.